Good afternoon, everyone. We're excited to see folks joining our call. We'll give a second for folks to come into the meeting. And while we're doing that, I'll go ahead and introduce myself. I'm Shelley Ellis, the director of the ICTR Dissemination and Implementation Launchpad and professor in the Division of Hematology, Oncology, and Palliative Care here at UW-Madison. You are signed on to the Implementation Science Seminar Series. This is a monthly interactive seminar to explore the field of implementation science. We meet on the second Friday of every month from 12 to 1 Central Time during the academic year. The seminar is open to everyone, not just at UW-Madison, so feel free to invite your friends. This seminar series is also part of the Implementation Science and Community Health Outcomes Certificate program that we have at the UW. It addresses the gap between basic research discoveries and their application in clinical and public health practice. So if you have graduate students or are a graduate student, you might be interested in applying for that program. And I know the application period is open right now. So you feel free to take a look at that on the ICTR website. I am delighted to be hosting this seminar. It's a real pleasure to be able to listen to some of the most forward thinkers in our field of implementation science, people right here at the University of Wisconsin, but also across the country. So today I'm thrilled to introduce a respected colleague, Dr. Ramzi Salloum, who's professor, associate chair for research, and the chief of the Division of Implementation Science and Health Interventions in the Department of Health Outcomes and Biomedical Informatics at the University of Florida College of Medicine. Dr. Salloum also serves as Associate Director of Community Outreach and Engagement at University of Florida's Health Cancer Institute and the Director of the Learning Health System program at their Clinical and Translational Science Institute. Dr. Salloum's research focuses on the implementation and dissemination of evidence-based practices, especially in cancer prevention and control. He has a demonstrated research record in the area of health services research across health systems and policy settings, with a particular focus on the implementation of evidence-based programs. His work has been funded by NIH, ARC, PCORI, the Florida Department of Health, the International Development Research Center, and Cancer Research UK. He is well-versed in implementation science methods and frameworks and has served as faculty for NCI's Training Institute for Dissemination and Implementation Research in Cancer. We call it TIDIRC. And in his spare time, he teaches fundamentals of dissemination and implementation research. Also joining us today is our esteemed colleague at UW, Dr. Andrew Quanbeck, who's an associate professor in the Department of Family Medicine and Community Health and honorary associate in the Department of Industrial and Systems Engineering. Dr. Quanbeck heads the Implementation Science and Engineering Lab here at UW-Madison. His research draws upon concepts from systems engineering to develop innovative approaches to implementing evidence-based practices. He is PI on 4 NIH-funded R01s that use innovative systems engineering approaches to promote the implementation of evidence-based interventions for the prevention and treatment of substance use disorders. Dr. Quanbeck is chair of the Osher Center for Integrative Medicine's Collaborative Research Committee. He's an associate editor at MPJ Digital Medicine and a member of the editorial boards of the journals Implementation Research and Practice and for Nature's Scientific Reports. He's also a former standing member of NIH's Science of Implementation in Health and Healthcare Studies section. So at this time, I'm very pleased to turn it over to Dr. Salloum and Dr. Quanbeck. And if you have questions or comments as we go, please put those in the chat and we'll address them in the discussion. So thank you for being here, Ramzi.
Thank you, Shelley, and I'm honored by the invitation to present to this group. And also, it's always great to spend time with you and with Andrew, although it's virtual this time. So let me see if I can share my screen. So I'm going to start by laying some of the ground for economics, the intersection of economics and economic evaluation, implementation research, and then transition a little bit to talk about the economics of adaptation. And then Andrew, I think, is going to follow me to talk more about the role of adaptations in implementation science. So I'll start with giving a rationale for economic evaluation implementation science. And some of you may be who have done some of this work before, this may be review for you, but essentially implementation, active implementation requires resources. And so understanding resource needs is critical for planning and sustaining evidence-based interventions. One of the key questions in implementation with that decision makers ask is the cost of an intervention or a program before they can make a decision to adopt that program. Of course, the underlying question here is whether the program is worth its cost and what is the return on investment, which is sometimes as researchers, we're not always prepared to answer those questions, but this is something that's typically what's flowing through the decision maker's mind. Oftentimes it's a healthcare executive or it could be somebody else in a different setting, but it's essentially a person who's going to write the check or pay for the program. It's important to understand that costs vary across stakeholder groups. And in implementation research, that difference matters. Especially because there's an active decision being made about whether a program or an intervention is going to be adopted or not. So sometimes different perspectives are needed at different stages, and so it's important to understand the research question about that you have, and who do you need to demonstrate the value to, which stakeholder group. Costs are also critical beyond the initial adoption decision when we're thinking about scaling up our evidence-based interventions and programs beyond the initial setting and into other settings or additional practices. And also, there's obviously a link between cost and sustaining interventions over time. So very important beyond the initial adoption decision, which and oftentimes we're thinking about just getting something into practice initially. One other thing to consider is that comparing implementation strategies, which is what we're often concerned with in implementation science, can be difficult without having standardized costs. Because if we don't have information on costs and we can't translate those costs across different strategies and settings, then we're not looking at the full picture in terms of reproducing the intervention, the effects of the intervention, and its implementation across different settings. So over the past few years, there's been a proliferation of articles and work, and also in terms of projects that include economic evaluation components in implementation science. There was a working group that convened implementation scientists and economists to talk about this issue, and there are several papers that have been published over the past few years in a collection in the journal Implementation Science and Implementation Science Communications that I'll reference at the end of these slides. This is one of those papers that was conceptualizing the economic consequences of implementing interventions. This article was led by Heather Gold and colleagues, so in this case, typically when we're thinking about healthcare interventions, let me see if I can get my pointer here. Oops. Sorry about that. In the middle box, you see here the intervention costs, which is what you typically see in a health economic evaluation of a healthcare intervention. So we're thinking about changes in the use of healthcare resources as a result of the intervention, and other types of resources. And then we're comparing that, if we're thinking about a cost effectiveness analysis, against a change in health outcomes or health status. When we look at an implementation research study, we're adding implementation strategies typically to the mix. And so it's important to think about these additional resources that are used to execute the implementation strategy above and beyond the cost of delivering the intervention alone. And also, because we're thinking about multiple stakeholders typically, and typically thinking about longer term sustainability and scaling up of the intervention, downstream costs also become really important. So typically, sometimes economists refer to some of these as opportunity costs, with respect to changes in the use of healthcare resources and other resources that would not have occurred if the intervention isn't adopted and sustained in practice. So there are additional cost considerations to be thinking about in an implementation research project compared to a healthcare intervention assessment that includes an economic evaluation alone. And then our colleague Andy Eisman and her co-authors also thought about and presented this comparison between intervention evaluation and implementation evaluation that I find really useful, specifically in this table. So there's a lot going on, but if we think about the different characteristics or dimensions of economic evaluation, starting with the relevant costs, which we talked about in the previous slide. So in an intervention evaluation, we think about the discrete costs associated with the intervention versus in implementation, we're thinking about adding implementation strategies to the mix. And what that does is also brings on the flip side, in terms of the outcomes, for intervention evaluation, we're typically only thinking about clinical outcomes. In implementation research, we add implementations and service outcomes in addition to clinical outcomes. So oftentimes our economic evaluation of an implementation initiative also includes additional outcomes in the equation in addition to our clinical outcomes. The time horizon can also be longer because we're thinking beyond initial adoption and into sustainment. And when it comes to the perspective, for traditional, when I say traditional cost effectiveness, typically there's a societal perspective that gets presented because these interventions are sometimes are presented without the context that often without the context that they're being implemented in. Whereas in implementation science or implementation research, we're very interested in the context, and so typically the perspective that we're thinking about is much narrower, and we're thinking about the decision maker who makes that adoption decision or initial implementation decision or the decision to sustain the intervention. So while the perspective can vary in a traditional intervention economic evaluation, in implementation evaluation, typically there's more of a focus intervention on who's implementing, who's making that decision. When it comes to study design, there's more focus on, given the stage of the research, there's more focus on internal validity and rigor in cost of in economic evaluation, whereas some of these may be more, that approach might be more pragmatic and maybe thinking about the costs and resources that matter for the adoption decision, for the sustainment decision, when we're thinking about implementation evaluation. And again, we talked about context being important for implementation evaluation, and that context comes into to the analysis. So oftentimes, for example, sensitivity analysis is used to look at variations in implementation determinants, whereas to a certain extent, when we're conducting an evaluation of the intervention, we're conducting that in a somewhat of a bubble. Although, and historically there have been research questions that have included implementation context in the evaluation, and perhaps without, being the research being framed as implementation research. And typically, as I mentioned earlier, the decision maker in this case, if we're talking about healthcare intervention specifically, the typical decision maker is the person or the stakeholder that is writing the check or paying for the intervention. And so these concepts, for the most part, have been embedded in implementation science frameworks as these frameworks have been developed, and it's also kind of inherent in hybrid implementation effectiveness studies that are typical that we typically see in implementation science. And there are some guidance, or there's guidance that's provided in some of the evaluation frameworks, such as Proctor's framework, that calls for the specification of implementation strategies by defining the actors, the actions, the targets, temporality, and those that are really critical when it comes to understanding implementation costs. And so those are useful as in terms of guiding the work or understanding what to measure in terms of the resources, relevant resources. And then over the past few years, there's been more work, applied work done using costing, different costing methods such as microcosting, specifically applied in implementation research. One of those methods is the time-driven activity-based costing. There were also methods like coins that were specifically developed in implementation science, and then budget impact analysis, which is used in healthcare organizations, has also been presented as a useful tool in economic evaluation. So we'll talk a little bit about these individually. So time-driven activity-based costing has been widely used in other academic settings and in business applications. And it's useful because it breaks down the implementation processes into discrete activities over time, and can help in terms of being able to measure these costs. And the citation that we have on the screen here by Shadav and colleagues is useful in terms of seeing an application that breaks down the costs of implementation into specific time-driven activities, but also there's a nice visual reporting in this paper by implementation strategies, and also by a breakdown of specifications of the implementation strategies that we see in Proctor's framework. So it's a useful application example to review further. So COINS was developed by Lisa Saldan and colleagues, and it was, as I mentioned, it was the first published approach specifically in implementation science to think about cost evaluation. And it's useful and really nice to apply because it breaks processes down or activities down by implementation phase and then stage. And so it provides somewhat of a checklist approach to go through an implementation process and think about the resource needs. So that's another way to be thinking about implementation cost evaluation. And then we have budget impact analysis, which is useful because it explicitly models both the costs and budgetary impacts of implementation efforts, particularly in health care organizations. And so it's geared directly towards organizational decision makers that will be asking the question about how much does this program cost, how much is it worth it, and what is the return on investment. And so it provides a discrete answer to should we adopt the intervention or not. And so that's in terms of measuring costs. Now, in terms of evaluation, economic evaluation, which typically adds the outcome component to the cost, traditionally we've had different tools to conduct economic evaluation. And so we have cost effectiveness analysis, which typically compares the cost per unit of a health outcome, but in implementation, that could be an implementation outcome instead. So instead of thinking about effectiveness, we're thinking about an implementation outcome like reach or cost per adoption. Other tools that we have in terms of economic evaluation is cost utility analysis, which thinks about or considers whether clinical outcomes are impacted using quality adjusted life years. Cost benefit analysis, which converts outcomes into dollars when possible. That doesn't always work, but for things like reduced hospitalizations, that could be an example where a cost benefit analysis can be applied, and that could be used and also could be linked to budget impact analysis. So here's a demonstration. This work by Michaud and colleagues demonstrates how we can add implementation outcomes into a cost effectiveness analysis. So beyond measuring effectiveness, we can look at cost effectiveness, with the effectiveness being an implementation outcome rather than clinical effectiveness. So it's a nice visual that shows how thinking about a trial that is testing different competing implementation strategies, we can think about the cost of the strategy in terms of the implementation outcome that it's directly impacting. So breaking down the effects of that strategy into which components are impacting reach, which components are impacting adoption here, implementation and maintenance, using the RE-AIM evaluation framework. So that's that's the difference between a traditional cost effectiveness analysis, thinking about effectiveness, and then here adding implementation outcomes to the mix. This is another nice example that also have the citation here. This is a very busy slide, but it's useful. It's very useful. This is a study that's using the EPIS framework to look at different methods that involve measuring and evaluating resources and costs. And so going through the phases of implementation, from exploration to preparation to implementation and sustainment, how the different needs of the project evolves using multiple different types of methods. So taking the simulation as an example, it starts out in exploration by reviewing existing studies to identify effective and cost-effective evidence-based interventions and implementation strategies to identifying those that are most relevant to the stakeholders in the preparation phase, and then estimating the usual care outcomes in the implementation phase versus how those would vary by if they were impacted by implementation strategies, and thinking in the sustainment phase about the project's long-term impact, or the intervention's long-term impact. Which brings us to talking about adaptations, which are part of every implementation effort and every implementation research project. So this is from an article that was part of this collection that I collaborated with Andrew and other colleagues on, conceptualizing the economics of adaptation. So thinking about adaptations, which again are inevitable in implementation processes, and thinking about breaking down evidence-based practices into core components and then adaptive components of the of any intervention. Some of those are planned during the implementation process, whereas others are unplanned and potentially reactive. So when thinking about costs, there are cost components that influence the core components of an evidence-based practice, and those are perhaps more critical in terms of thinking about reproducibility of the adaptations. And we're thinking about, is an adaptation worth it, or how much does it cost to make that adaptation? Those are things that we probably want to focus on, because those are impacting the core components of the evidence-based practice. And then we have a planned adaptive. We also have planned adaptations that sometimes we're going to be interested in asking how much those costs, were those worthwhile, those adaptations. And then we have unplanned adaptations that will also are unexpected. So we would be asking questions around the marginal estimates of unexpected incremental costs, and sometimes those may be outside of the perceived bounds of implementation costs, because they may be things that are happening in the outer setting, and things that are really difficult to factor into an implementation decision. And so integrating that concept of thinking about cost specific to implementation strategies versus the intervention versus downstream costs. Here we apply it in parallel to thinking about core components and the costs associated with core components with the planned adaptive periphery versus unplanned adaptive periphery. And so in terms of thinking about adaptations, the same concepts or the same tools that we use to think about economic evaluation in general are going to apply, because oftentimes we're asking whether the adaptations are worth it. So thinking about the adaptations as perhaps an intervention in themselves, and whether that was a useful action to take. Sometimes adaptations occur because costs change, or because a certain paradigm is too costly. So that's also important to understand. But essentially, the first step in any adaptation is to understand, to better identify and characterize the adaptation. So using tools like the Frame or the Frame IS tool to document the adaptation. Preferably, this should be done prospectively, or proactively versus reactively, and there's always recall bias if this is done after the adaptation takes place, or after some time has passed. And then if this is being done proactively, then presumably we're able to capture the resource and cost changes that occur with the adaptation. If we have a process in place like a micro costing approach, and we ahead of time we recognize that there will be adaptations and that we are going to be measuring the impact of those adaptations. And then this also needs to be baked into our assessment of outcomes. So having a flexible approach to measure changes in outcomes as impacted by the adaptations would be important if we're trying to understand the value of the adaptations. And then you would conduct your economic evaluation, run sensitivity analysis based on the scenarios I presented in the prior slide in terms of which adaptations matter, which ones are replicable or important to reproduce in an analysis. And as with any type of analysis, it's important to get, in terms of an implementation evaluation, it's important to get feedback from stakeholders and their interpretation, and then be able to, with all that information, which is really hard to do in real world settings, then presumably you would be able to make a value-based decision, whether to scale or modify further or discontinue the adaptation. That's an evidence-based decision. So I'll stop here and hand the gravel over to Andrew.
All right. Thank you, Ramzi. I'm going to try to share my screen, so let me know how this goes. Okay, does that look okay?
Looks like you're sharing your presenter view.
Okay, how's that?
Perfect. Thank you.
Okay, thanks. Well, hello everybody. Good to see you on this Friday, and thanks again for the opportunity to address the group. Appreciate it. So I wanted to kind of take off on a theme that Ramzi introduced on the role of adaptation and implementation research. I think all of the information on economic evaluation is really important, and I've included economic evaluations in all of the studies that I've led. And I think it's just really important, that question about what is the cost of the intervention, the cost of the implementation is so important for decision making and sustainability that it really needs to be a part of any implementation, really rigorous implementation project, in my opinion. So those are the funding for my research. I also have some disclosures to make. So in preparing just some brief remarks for this, I dusted off the paper that Ramzi led and I contributed to from a few years ago about the economics of adaptation in implementation research. And so this is a quote from the paper. It says, "The origins of adaptation can be traced to its roots in the diffusion of innovation theory, originally defined as reinvention and discussed as early as 1972 by Charters and Pellegrin. Originally thought to be unambiguously negative, reinvention has increasingly been recognized as a fundamental part of the adoption and implementation process." So, the original idea is like, well, we have an intervention and we just want to implement. The implementer knows best about what should be implemented. We're striving for fidelity, and we don't want to mess with anything. But over time, it's been recognized that it's really adaptation is a strategy that can help foster adoption. So having some flexibility in innovations and the ability to reinvent and adapt helps promote adoption more rapidly than rigid interventions. Sustainability, when users modify an innovation to fit their context, they feel a sense of ownership that makes them less likely to discontinue usage later. So this, I think, is an example of something called the endowment effect for those, so kind of making a tie from health economics to behavioral economics. There's a famous experiment called the mug experiment by Danny Kahneman and others, where basically people are given a mug and then have the opportunity to buy and sell it, and individuals who were given a mug, the sellers demanded a higher price to part with it than buyers were willing to pay, driven by loss aversion. So roughly, people who were given the mug value it about twice as much as people who have the opportunity to purchase it. So there's a real differential there. So if you think of your intervention as a mug that you're trying to transfer and sell to an implementer, you have to, adaptation is sort of a process by which you can transfer ownership of the intervention and the idea from the implementer to the adopter. So it turns the adopter from a passive consumer of technology or interventions into an active partner in the innovation process. So just briefly, I've used adaptation in my own research. So this study was published in late 2024, where we were implementing a digital health app for alcohol use disorder in a primary healthcare system. So we built in our grant application the first year. It was guided by the EPIS model: exploration, preparation, implementation, and sustainment. So the first year we spent talking to stakeholders from the healthcare organization, including patients, primary care physicians, organizational leaders, health coaches, understanding like how would this operate within the environment that we want to implement it. So that led to pretty significant adaptations to the intervention, so that it would follow sort of the health coaching model used by the healthcare organization, follow some of the principles of care that are used. So it really that process of exploration, gathering stakeholder input from multiple levels, led us to redesign and reinvent our intervention to something that was going to be acceptable and usable for patients and individuals in the healthcare system, and something that leadership could get behind. So I think it's a really important step in really any implementation project. So kind of tying this back to more contemporary writing about implementation science. Again, I went back to Rogers, and they're talking about reinvention in 1972. This is Proctor's implementation outcomes framework from 2011. So it lays out all these different implementation outcomes, service outcomes, and client outcomes. And I've kind of maybe foreshadowed the way that I think adaptation fits, but I wanted to just close with these remarks and open it up for discussion and questions. But I think I'd be interested to hear what people think about how adaptation fits in the Proctor's outcome framework. And to the extent that many of you do your own research, what's been your experience with adaptation and the role that it plays? And I think with that, I'm going to turn it back over to the open session, and we have about 20 minutes left for just kind of free-ranging discussion.
Andrew, I'm just curious, would you think about adaptation as a moderator of those outcomes? in Proctor's model?
Yeah, I mean, I think that's kind of the way that I think about it. I mean, I could, in my view, so I took the slide down, but there's acceptability. I think that to make an intervention acceptable to an audience, you need to do adaptation, and adaptation is sort of the antithesis in some ways of fidelity, because if you're really striving for perfect fidelity, you would not be allowing for a lot of adaptation. So I think every intervention you have to kind of strike the right balance. That's why I think the recommendation in the paper to use a framework like the frame, so you can say here's how this was intended, but then carefully document the changes, and then the extent to which you can cost out those changes is always a good idea. But yeah, the changes might lead to lower costs or higher costs. It can definitely vary, but that's kind of the way that I think that's kind of the way that I think about it. You have to balance. There's sort of a balancing act with these, and I think adaptation and fidelity are closely related, and you have to strike the right balance.
Hi, Dr. Kornbeck. Can you hear me okay?
Yeah.
It's Emily Thompson. I took your class last spring, so
Oh
hello.
yeah.
Good
Hello.
to see you. Thank you for your information. So bouncing off of the balancing act, I'm just wondering what you should have in your forefront, like the forefront of your mind when doing that balancing act. Should it be the project itself? Should it be the economics of the project? Like, what would your recommendation be?
Yeah. Well, I mean, it's a good question. I think probably most, in the research studies that I've led, the goal is to try to implement interventions and get them adopted. So this might be my own bias as a pragmatic person who does a lot of research, but I think that, whatever can be done to promote adoption of the intervention, is what I forefront. But then I think you just have to, make sure that you're sort of holding true to the. So this is part of the kind of art and science of being an implementation science or intervention developer, is understanding what can reasonably be adapted for an intervention, without losing, what we expect to be, what's going to deliver effectiveness. So that's kind of the trade-offs that I think about. I think this outcomes framework is comprehensive enough that all should be considered, and then all just kind of need to be balanced. So I don't know. It's a tough question, and I found different kind of approaches for different projects. I think you have to. The issue with stakeholder engagement is if you're going to do it, then you really have to listen to what your stakeholders say. Otherwise, it's not worth doing. So I don't know if Ramzi has anything to add to that.
Yeah, I mean, I think it's also important to think about the nature of the adaptation, and whether it's planned or unplanned. This is also captured in the frame. We've been using the frame to code adaptations in a lot of our projects. Some of them, and I think it depends on the nature of your study design. So we have, if you're conducting or leading an implementation trial, you have the opportunity to be more proactive about measuring the adaptations when they're occurring. And we have that experience now with some of our implementation trials where we're following the adaptations as they occur. Sometimes that's not possible. We have another project that's focused on studying sustainment of an implementation initiative that's not designed as a trial. This is the Cancer Center Cessation Initiative, which is coordinated, which the UW serves as a coordinating center for. And so in that case, it's most of the measurement of adaptation is happening retrospectively, which makes things a little bit more difficult. But thinking about planned uh, versus unplanned and proactive versus reactive adaptations, the purpose of the or how the adaptations happens also could influence potentially um, the evaluation strategy. So thinking about the adaptation as a moderator, or if you're the economist, you might be thinking about the adaptation as an intervention in itself, perhaps, and building your economic evaluation around the adaptation as a thing or as an intervention. Whereas in implementation science, it's something that's happening as a moderator. I can't claim that I've tested that empirically, but I think it's a compelling question. And it just depends on the size of the adaptation and how critical it is. And some adaptations don't cost a lot, perhaps, or don't require a lot of resources, but they may have serious consequences. So it depends on also the resource needs of that adaptations in particular. Some adaptations are critical. They could be very simple or subtle, but they could lead to major consequences.
I see Reed has his hand up. Hi, Reed.
Yeah.
Do you want to pose your question?
Yes, please. Thank you. Thank you, Andrew and Ramsey. Great presentations. And Ramsey, you started to hit on what I wanted to ask about there. And I wonder about going the other direction. So similar to how impact analysis is that higher level, almost a zoomed out way to capture some of these changes in cost or budgets, right? If we look at adaptations over that sustainability period, or even just those really long-term implementation projects, have y'all seen any ways to capture, oh, hey, this adaptation happened that maybe we didn't catch early enough, but we're starting to see some effects because we can't always be Johnny on the spot with frame ready to go, right? Have you thought about that kind of higher level view or maybe some more system level ways to monitor for those? And sorry, the questions to either one of y'all or anybody else on the call.
Yeah, I mean, it's a great question. It's, I think, so we're trying to do that, but we have, like with our sustainability study, which, it's, but it's, there are limitations if you don't have, if you don't have the data to track the adaptations. We obviously use mixed methods in that project to try to have a complete picture of what occurred in the implementation slash sustainment trajectory. So thinking about the roles of adaptations using or explaining them using mixed methods is what we're doing. I think with the obviously now with new AI methods and more informatics methods, there are opportunities to be able to track implementation processes, especially with implementation projects that rely on technology like EHRs and clinical decision support tools, to be able to track those adaptations and be able to go back retrospectively and assess the consequences of adaptations without having your clipboard and frame in hand.
Yeah, I would second that. I think there's definitely an important role for qualitative research in any. I mean, I think there's people have written about this because you can't really predict everything that's going to happen. So I think you have to just have structured ways of going back and talking to people in more of an unstructured format to capture, the things that don't lend themselves to codification with something like frame. So yeah, include, I should say that in addition to economic evaluation, we have qualitative evaluation in all of our studies, and I think they all work together to create a full picture of, both for implementation planning and also implementation evaluation over the long term. I see there's some questions in the chat, so maybe we can. From Shannon, could you comment on an approach to thinking about economic evaluation relative to the size or scope of the implementation efforts? These frameworks be applied to projects of any size. Is planning in chunks more effective? Does it get prohibitively risky to form economic evaluation frame for a huge project? I mean, I can give my initial thoughts. I think it's good to include at least cost assessment for any scale of project. I think if you're getting to a level of, a health system implementation or an R01 level implementation research grant, having some type of formal sort of method of trading off costs and effects, which doesn't necessarily need to be cost effectiveness analysis. I know one of our colleagues, Todd Wagner from Stanford, has sort of provocatively said that cost effectiveness analysis should be de-implemented from implementation science, which in some cases makes some sense to me. I think you have to have some way of looking at trade-offs. So for the most recent cluster randomized trial that we completed, I didn't think that cost effectiveness analysis worked very well, but I think budget impact analysis did work. So we've just published a budget impact analysis where we costed out the implementation strategies associated with implementing clinical guidelines for opioid prescribing in primary care settings, but then also looked at the healthcare utilization changes that sort of derived from the implementation efforts, because those guidelines, told health systems to do certain things that had costs associated with them, like urine drug testing and time-consuming screening and treatment, agreements and things of that nature. So it's a complex question, but I would say, it's important to just know like a basic kind of back of the envelope. Okay, what is this going to cost to replicate? And if you're doing multi-site research, I think you have to look at trade-offs between costs and outcomes. But there's different ways of doing that: cost-benefit analysis, cost-effectiveness analysis, budget impact analysis. And I found budget impact analysis to probably be the most pragmatic one that seems to work for health systems in my experience.
Great, thank you so much.
Mm-hmm. I'll definitely agree with what Andrew said, and there are obviously pragmatic considerations depending on the size of the project. I think also another important question is making sure that you're understanding what costs are important to your decision maker, to your stakeholder, and for replication. So that's a question that I get asked often: is should we observe this, this activity, or do we need to observe this activity? And it all goes back to judging whether the activity or that process is going to be important for the decision maker, and also be something that will be replicated when you take this intervention and apply it in another health system or another clinic. And so those are considerations that give you that flexibility when you're doing economic evaluation and implementation research versus when you're doing a more kind of controlled analysis that requires you to be comprehensive about observing everything, or coming up with a cost for every piece of the puzzle.
Thank you.
So a couple of questions in the chat still I'm hoping that we can get to. Anand was wondering about your thoughts about RCT adaptations, safety net hospitals, FQHCs, or rural hospitals that may not have the same infrastructure from conducting research studies.
Yeah, it's a good question. I mean, I think I have done some work with FQHCs. We didn't have a very specific focus on adaptations or economic analysis, although some. I mean, I think the important thing is understanding the organizational structure and kind of the way that it's financed, and organizational values can vary quite a bit between an academic medical center with sort of a different mission than federally qualified health centers who are there to serve individuals regardless of their ability to pay. So I think, and I can't claim to understand those models well enough to speak all that intelligently about them, but the way that I've approached it is that stakeholder engagement, just making sure that you're talking to leaders of organizations to kind of understand what their decision-making trade-offs are. Costs can be construed in lots of different ways, money, time, and then the outcomes that you're looking for, might be more financial in a academic medical center versus, more mission-driven in a federally qualified health center or safety net hospital. But then just, making sure that you're aligning your evaluation with the organizational mission, I think, is the important thing to consider.
One thing that I'll add is that one of the facilitators in that case, from my experience, is that when you start talking and engaging FQHCs, safety net settings, clinics, etc., they're obviously going to be very cost conscious and thinking about resources from the beginning. So sometimes they're going to be this is definitely, as Andrew said, you need to engage them in that conversation, and this is something that they're going to care deeply about, and to understand the costs and resources that it requires to adopt the program or the intervention, and then also to sustain it. So so you have a captive audience in that case, and they're gonna, if you engage them early enough, they're gonna be partners in terms of being able to observe and also think about the consequences of adaptations and their costs.
Fantastic. So I want to thank Ramzi and Andrew for being here today. This is an important issue for many of the folks in our Implementation Science Network here at UW, and we're grateful that you were able to share your expertise. Just to let you know, our next seminar will be on Friday, March 13th. We have Jay Ford, an expert in facilitation right here from UW, who is going to be talking about different iterations of how one might do facilitation as an implementation strategy. So we're very much looking forward to that. We've included a link to our evaluation for the seminar series, and we'd be grateful if you would give us feedback and comment on other topics you might be interested in us covering in future seminars. So thank you very much. If you want to find additional implementation seminar series material, we have a YouTube channel for the ICTR D&I Launchpad, and you can find previous seminars that we've hosted on that channel, all on our website. So thank you all very much, and we'll look forward to seeing you next month.